So my name's Ian McLaren. I'm a consultant in intensive care medicine at Leicester Royal Infirmary. What I'm going to talk about this afternoon is delirium in the intensive care unit. And particularly for those of you who are fairly recent joiners of the intensive care community, hopefully this will provide a little bit of clarity about what delirium is, why it's important, how we can treat it potentially, and potentially how, much more importantly, we can prevent it. So it's very common at any ICU ward round or any sort of morning or evening handover to say, oh, the patient in bed 4 last night, they were delirious, they pulled everything out, pulled all the lines out, caused chaos, we had to sedate them, we had to give them some haloperidol, and everything got a bit better after that. Well, quite often that's not delirium. Quite often that represents agitation, and agitation is characterized by all those things that you think of. The patient might be hypertensive, tachycardic, obviously anxious, will pull stuff out, difficult to sedate. But the thing about agitation is if you take the cause away, the agitation stops. The difference with delirium is that that disturbance continues and may or may not be obvious. So how do we define delirium? So this is the DSM-4. So the DSM is the sort of psychiatric list of disorders, if you like. And DSM-4 defines delirium as a disturbance of consciousness with inattention, accompanied by a change in cognition or perceptual disturbance that develops over a relatively short period of time and then can fluctuate over time, and it may be quite prolonged. And actually, when you take away the stimulus that is causing it, it carries on. So that's where it differs from agitation. And remember, agitation may also be due to something like pain, so we have to address all those things as well. So what are the neuropsychiatric features of delirium? So there's a disturbed level of consciousness, an alteration in the normal conscious level. The patient is unable to focus or sustain or shift their attention. And they develop quite severe perceptual disturbance. So they develop hallucinations. And if you talk to patients who have suffered from delirium and can remember it, they know that what they were seeing wasn't real, but they couldn't do anything about it. It was very real to them at the time. There was a very good description given by an intensivist who suffered a major illness, who underwent surgery, and he had delirium, and his delirium manifested as he thought he was floating above his bed and then flew through the window and fell several stories and smashed into hundreds of pieces, and he was crawling around trying to put himself back together. He knew it wasn't real, but it was very frightening at the time. So what are the sort of motoric motor features of delirium? So there are 3 types of delirium. The least common is pure hyperactive delirium, and probably only about 2% of patients with delirium have a purely hyperactive form. That's the bit we all recognize, and it's the bit we mix up with agitation. So they're the patients that are agitated, aggressive, pulling at stuff, won't comply with treatment, or maybe saying they have hallucinations, seeing things, grabbing things out of the air. There's a much larger group who have hypoactive delirium, and they become very withdrawn, very slow. You don't notice them because they're the patient that's behaving perfectly well. They're the one lying in bed quietly, not bothering anyone. But actually, internally, they may be in complete turmoil. And much more common is a mixed picture, which is characterized between fluctuations between the hyperactive one had periods of hypoactive delirium. The prevalence of delirium in ICU patients varies, and various studies have looked at it. Historically, it was very high, well into the 80% when it was first recognized. And people used to talk about ICU psychosis before they recognized this as delirium. And there's probably a number of explanations for such a high figure. Going back to when I started intensive care in the mid-80s, our patient population was very different. We had a lot of patients with trauma, we had a lot of patients post-surgical and neurosurgical, and we had patients, a lot more patients with ARDS for various reasons. And to manage those patients, things like ventilators were much less sophisticated than they are now. So you actually needed to sedate people relatively heavily for them to comply with ventilation. So it wasn't so much the patient driving the ventilation, but the ventilator ventilating the patient and battling with the patient. And so they had a lot more sedation. They had patients who had a lot more higher incidence of ARDS. And I'll come on to it in a minute, why that might be important. And it was something we never really recognized. We knew people got this psychosis, but we didn't realize the damage it was doing them. And we had a lot fewer patients that were awake, because patients, when they were off the ventilator, they were sent to the ward. So we never saw the consequences. More recent studies have shown prevalence down into the 30s or even below that. Most studies vary between about 20 and 30% for the prevalence of delirium in ICU patients. It's certainly more common in patients who've been ventilated, patients that are intubated, and again, there might be a number of reasons for that we'll come to. And it's more common in older patients, patients who are already encephalopathic for some other reason, sicker patients as well. The phenotypes of delirium are variable. So some of it is due to sedation and our choice of sedation, and in particular, the benzodiazepines seem to be particularly deliriogenic, which is why we don't now run people on high doses of benzos, and we don't really like giving people lorazepam if they're agitated or delirious, because they are quite deliriogenic. But that is often reversible. Hypoxia, and particularly tissue hypoxia and particularly brain hypoxia, are associated with very high levels of delirium. And this probably, if you have hypotension despite adequate blood oxygenation, particularly in the elderly patient who may have a more limited cerebral capacity to deal with fluctuations in blood pressure, then those patients are more at risk of developing delirium. And it also explains why there was such a high incidence in ARDS patients. I don't know what the incidence is in ECMO patients. I haven't found any data on that, but you could postulate that they may well end up with higher levels, high prevalence of delirium. Patients with sepsis, and that uses the old-fashioned definition of suspected infection-induced host criteria, but patients with sepsis are particularly at risk. And patients with a significant metabolic disturbance are characterized by high ureas or low sodiums or high sodiums, or markers of liver inflammation or hypoglycemia. So breaking down the risk factors into sort of patient factors and chronic health acute factors and environmental factors. So age, as we say, plays a major role. If you're older, you're more likely to suffer delirium. If you consume significant amounts of alcohol on a regular basis, if you smoke, you're at higher risk. Patients who already have dementia are at very high risk of becoming delirious. And patients who are normally hypertensive, so again, reflecting possible variations in autoregulation, with brain oxygenation. Patients with cardiac disease and sicker patients. So if you have a high ASA, then you're more likely to develop delirium. The actual acute reasons for your admission, so if you're in coma for any reason, that has a much higher incidence of delirium and a much worse outcome. I'll show you some data on that later. If you have a high Apache score, again, it tends to go with coma. If you've had an emergency procedure, you're mechanically ventilated, you've had multiple trauma, you're severely asthenic, so all reflecting quite pro-inflammatory states. If you have fever, or even if you're a medical admission is slightly less than emergency surgical admissions in terms of the deliriogenic factors. And then really importantly, environmental factors. And that's something we do have some control over. We can't control who's coming in the front door, but we have some control over the environment we manage them in. And here at the rest of our environment, we manage them in a particularly deliriogenic environment. If you want to go into the annex and spot that there are no windows, so we have no daylight. If we give people benzos, they tend to get more delirious. Opioids, opiates, will be deliriogenic. Pethidine was probably the worst agent of all, which we don't use. Epidural analgesia is associated with it. However, that's not probably due to the epidural. It's due to the fact the patient's tied down to the bed by having an epidural, and actually physical restraint of any form, and that's lines, catheters, all the things that keep an ICU patient in bed rather than us physically tying them down, they all promote delirium. A feeling of isolation, so being stuck somewhere on your own doesn't help, and not getting a normal food doesn't help. So those are all the things we do to intensive care patients as a routine. Going back to the epidural is interesting. Whether you have a GA or an epidural procedure doesn't seem to affect whether you get delirium or not. So people often blame things like the anesthetic for delirium or the anesthetic for post-operative cognitive dysfunction, but patients having regional procedures also get delirium. So it's probably more inflammatory mediators caused by surgery that are causing the problem. So delirium is thought to be a neuroinflammatory response to some sort of insult. And the evidence for that is if you look at markers of glial activation like S100B, they are significantly raised. Now you see that rise in S100B in other situations where you incur cerebral damage. So patients with neurotrauma, patients with hypoxic brain injury, patients with encephalitis will all show the same picture. They also tend to have raised CRPs and raised procalcitonins, again as a marker of inflammation. And if you look on PET-CT, it seems to affect prefrontal and non-dominant parietal regions. You get some change also in the basal ganglia and thalamus. So it's not just the psychological effects of what we do to people in ICU. There is something triggering this on a physical basis, and that causes the long-term issues with delirium. We're actually creating a form of neurological damage. Why is it important? Well, you're significantly at risk of dying, or a greater risk of dying if you develop delirium on an ICU than if you don't. And that increased risk of mortality extends out into the post-ICU period. So there's a sort of 20 to 25% increase in mortality at 6 months in patients that have had delirium compared to matched patients that haven't. And it does cause long-term cognitive dysfunction, and patients coming back to ICU follow-up clinics will report this, and more importantly, their families will report this. And even patients who you think have recovered are never back to the same cognitive capacity that they had before they entered ICU. That has a big impact on patients and their families, it also has a big societal impact. And the last cost figures I could find is there was an estimate that in the United States alone, it costs something between $4 and $16 billion a year, the consequence of delirium in ICU. That's patients not being able to go back to their normal work, it's patients needing long-term care, the huge effect that has on families and patients. So a little bit tricky to see, but this comes from an American study looking at about 400 patients with delirium, looking at the outcomes. And you can see there at the top the Kaplan-Meier curves separating out. So, you know, at 6 months, there's that significant difference between the groups. And in the lower one is slightly more complex. That shows the same curves as the first two, but with two added curves. So the thick dotted lines are patients who were in coma, who looking at their survival. It was coma who didn't subsequently show signs of delirium, looking at their survival over the 6 months. And there's a fine dotted line which goes even further down, and those are the patients who had coma and delirium, and they were at very significant. So that's that curve there, joins there. So if you had coma and delirium, you did particularly badly.
What do they mean by coma?
Sorry?
What do they mean by coma?
So those patients who probably had a neurological injury or some other thing which rendered them with a low GCS when they were admitted to ICU, rather than being an artificially induced coma, pharmacologically induced. So long-term cognitive dysfunction is very important consequence of delirium, and one of the most distressing consequences of delirium. So about 25% of ICU survivors will have some cognitive impairment at 1 year. So all those people we get better, and get them out of the unit. A significant number of them will not return to their previous cognitive function. That has a big effect on obviously on themselves, but also their families and their social interactions. They may need more support afterwards. Some undergo some form of personality change. It's a different person who comes out of ICU than the one that goes in. And we have to be aware of that. We have to try and minimize that damage. So delirium seems to be the most important risk factor for developing long-term cognitive impairment. Of all patient groups, patients with ARDS are most at risk, and that probably reflects the pro-inflammatory but also hypoxic nature of ARDS. And it's a condition we see less often now for various reasons, but you still should be aware that those patients will have long-term cognitive dysfunction. In fact, some of them will develop PTSD, and the incidence of PTSD in ARDS survivors is roughly equivalent to people that have been in a war situation. So it is quite devastating. And the sort of sedation and analgesia we gave people during their ICU stay doesn't really seem to have a huge impact on cognitive dysfunction. It's more whether they develop delirium or not. So we've talked a little bit about what delirium is and the consequences of it and why it's important. So how do we diagnose it? It's not as simple as standing at the end of the bed and seeing someone who's pulling everything out, as I implied. That might just be agitation. And a lot of delirium patients don't manifest much in the way of signs, particularly if they're hypoactive in mixed cases. So we should screen our patients for delirium on a daily basis. And the recognized way of doing this is the CAM-ICU, the confusion assessment method for the ICU. And there's also an intensive care delirium screening checklist. And if you've ever turned over one of the ICU charts, you'll discover this stuff on the back of them. It took me a long time to realise it. Never told me. But on there is a delirium screening tool, among other useful things. So the CAM-ICU is the most commonly used. It's pretty sensitive and pretty specific. And it's been validated for use in intubated patients. So as long as you can interact with them, they don't need to be able to speak. Okay? And it's designed for daily use. So this is the CAM-ICU, and for those in the room here, it's a little bit difficult to see. If you're looking at on another device, it might be slightly easier. So the first thing is we look to see whether there's an acute change or a fluctuating course of mental status. And if there isn't, they're not delirious. Okay. But if it is, then you can look for inattention, and in a moment I'll show you a video of how this is done, and then you can look at their altered level of consciousness and look for evidence of disorganized thinking. So it's a little bit difficult to see here. So let's see if this works.
Patients can be ventilated or not ventilated on any station you like. The important thing is that they will open their eyes and keep their eyes open to a verbal stimulus, usually saying their name. I'm going to do the whole test, which is 2 parts, but in some patients you will only need to do the first part, and I will explain that at the end. Peter, my name is Valerie Page, and I'm one of the doctors looking after you, and I want to test how clearly you're able to think. So what I want you to do is I want you to give me your hand and squeeze my hand. I'm going to ask you just to squeeze when I say the letter A. There's 10 letters. Only squeeze the letter A. S. A. B. E. A. H. A. R. T. Okay, excellent. Now I'm going to ask you 4 simple questions, and it's a yes or a no. So nod or shake your head. Are there fish in the sea? Will a stone float on water? Is 1 pound heavier than 2 pounds? Do you use a hammer to pound a nail? Okay, finally, just raise 2 fingers. I want you to do the same thing with the other hand. Very good. Okay, that's all. So for the test for the CAM-ICU, you need a patient who has an altered mental status. In other words, a patient is not quite themselves as they would be when they're being entirely normal. You then look for inattention. We test for inattention by seeing can the patient pay attention long enough to squeeze correctly on the A's in a 10-letter sequence, say A heart, where heart is spelled with 2 A's. So if they squeeze on a non-A, that's a mistake. If they don't squeeze on an A, that's a mistake. And they're allowed 2 mistakes. If they have more than 2 mistakes, that's inattention. And you proceed to the second part of the test. If they have 2 or less mistakes, they don't have inattention. The test is complete, they are CAM negative and are not delirious. It doesn't matter whether they have 4 mistakes or 6 mistakes, any more than 2 is inattention. The second part of the test is looking for disorganized thinking, and there's 5 elements. So there's 4 questions and a command. They're allowed to get 1 element wrong. If they get 2 questions wrong, or a question and a command, they're unable to complete it, then that's disorganized thinking. Inattention plus disorganized thinking or a reduced level of consciousness is a ITU CAM-positive delirious patient.
So that shows you in practical terms how to do the test. So it's relatively straightforward and relatively reproducible. So how do we prevent delirium? So there are a number of guidelines in place concerning delirium prevention. We have our own UHL guidelines, which you may or may not have seen. They're not the world's most exciting read, but they're designed as a guideline. And they are the pain, analgesia, and delirium guidelines for ICU patients. And they set out our approach to things like sedation, pain management, and the management of delirium and the pharmacological management of delirium. There's a more full care bundle, which is produced by the Society of Critical Care Medicine in the States, who have done a lot of work on delirium. And that's the ABCDEF bundle, which I'll come to shortly, and also the Scottish Intercollegiate Guidelines Network. They're organisations sort of similar to NICE, but they produce some pretty solid clinical guidelines, and they have all produced the appropriate guidelines. So let's move that to full screen again. That's better. So our PAD guidelines differentiate the causes of agitation in the ICU patient. So pay attention to things like pain, and make the point again that agitation doesn't equal delirium. And they mandate the use of the RASS score to titrate sedation to a particular level. So let's have a look at that. We can think about causes of delirium. Again, that's a little bit small to see, but they are multifactorial. If you're looking on another device, you can probably read that. I can't read it from my screen, but they go through the things you need to look at and the things you can manage and the things you need to exclude. This is the RASS scale, the Richmond Agitation-Sedation scale, and this is used to document levels of sedation in the ICU patients. And you'll see this charted, and you'll see it on your daily review sheets. It says, what's the RASS? And that's what RASS means. And ideally, you want patients around sort of 0, -1, if you can, +/-2. You don't want patients deeply sedated in most instances. There are reasons you might need to, neuroprotection, but you don't really want deep sedation. And that actually is used by our nurses to titrate sedation levels to the appropriate level. So this is the SCCM's ABCDEF approach. Again, looking at things involved with pain, things involved with agitation and delirium. So you're looking at the monitoring for all those things. So pain, you can use visual analog scores. There's an ICU pain score that you can use, which is an observational tool. Agitation, I said we tend to use RASS, and for delirium we tend to use CAM-ICU here. So the ABCDEF is assessing and treating pain. It's doing daily sedation holds, so awakening trials. So every patient who is on continuous sedation should have that withheld, unless there's a good reason not to, and allow them to wake. The use of spontaneous breathing trials, again, so that patients aren't over sedated. And a lot of those things were quite new to the Americans. We were doing this much more in Europe than the Americans were. They were about 10 years behind what was going on in Europe in terms of spontaneous breathing trials, and they had a lot of patients more deeply sedated. It's about coordination of care. It's about choosing the appropriate sedation. Delirium reduction. So, you know, what can we do about that? Can we do things in the environment? Can we do things with reducing sedation, looking at the drugs we're giving people? And then E and F are much more about mobility, getting people up moving, involving families in care. So a lot of the stuff that you see our therapists doing is really important at reducing the incidence of delirium and reducing the incidence of post-ICU cognitive dysfunction. And you'll see a lot of presentations around the unit, a lot of posters looking at that. And it's worth reading those and seeing what our colleagues in therapies are doing to support our patients and help our patients. So what about sedation analgesia choices? You want to try and eliminate pain as much as possible, but try and do it with the minimum dose, or you use multiple approaches to that. I said before, avoid benzodiazepines. They're particularly deliriogenic. And there's been a lot of work on whether alpha-2 agonists may be beneficial at reducing delirium. And the picture from those is very mixed. There were some trials which weren't really powered properly, which showed a sort of tendency to have less delirium in the patients that were treated either with clonidine or dexmedetomidine. Perhaps the most recent large trial was SPICE-3 a few years ago, and that was comparing dexmedetomidine against propofol sedation and midazolam morphine. There were a lot of criticisms to be leveled at that trial, and in terms of survival, because that was what it was looking at, the dexmedetomidine group didn't do any better, and in fact there were some groups, younger patients with dexmedetomidine may have actually been harmful. There was a bigger incidence of adverse effects. In terms of delirium, the signals were there though that the alpha-2 agonists probably reduced delirium, so that was beneficial. So we will tend to use alpha-2 agonists to sedate patients, and they're particularly useful during emergence and withdrawal from other agents. They're very beneficial for that. There's no evidence that using haloperidol for prevention of delirium. It was thought for a while if you gave a regular small dose of haloperidol, that may be deliriolytic, but it's not. It can be useful in the acute management of delirium and acute agitation. It's relatively safe, but there's very little evidence for it preventing delirium. Olanzapine, on the other hand, might have some role, but no one's done the big studies that you need to be able to do this. Again, melatonin, a little bit of thought that might be a useful thing. Again, probably more around restoring normal sleep-wake patterns. So we do use some melatonin. So what about non-pharmacological interventions? And there's a lot of those that we can do. And a lot of them we don't do particularly well as doctors because we don't think about them. But actually, they're probably more beneficial than most of the stuff we do to our patients. So repeatedly reorientating them, you know, where they are, what day it is, what time of day it is. It's important. They need to have something to do. You can imagine lying in bed in our ICU for days and days and days with the same video playing on your TV, if you can hear it. pretty poor, really. Trying to get people into a day-night rhythm without the use of drugs. So keeping people alert and active during the day, giving them access to natural light so you know what time of the day it is, getting people mobilized. And I said before about physical restraint being a risk factor for the development of delirium. Get rid of catheters, tubes. If you don't need a line that's tying a patient to bed, get rid of it and get them up and moving. People lose senses, so if they don't have their spectacles there, they can't see and everything's a blur, that's not going to help them. Similarly, if they can't hear because their ears are full of wax, a significant number of elderly patients will come in unable to hear because they've got wax in their ears. No one in the community does anything about it. Basic things: dehydration, preventing dehydration, using good pain management, and minimizing all sorts of noise. The noise of an ICU is tremendous. If you're in bed 10 and your head's next to the central monitoring, which constantly is alarming day and night, and people are banging bins, answering phones, chatting, it is very, very deliriogenic.
Really bad at having full conversation.
Yeah. It's my favourite non-pharmacological intervention. Most of you will have met Scylla, who is our Petra's therapy dog. So she's a great intervention. She's a great staff intervention as well. So the environment's important. So during COVID, we were occupying the whole of PACU, including the paediatric bed. So some of our COVID patients were waking up from coma, having been very hypoxic, having been very heavily sedated, and then being faced by seeing that. And it was little wonder that they were delirious. If they weren't delirious, they probably thought they were seeing space monsters and things on the wall. Involving families with care is important. Again, during COVID that disappeared, but they are a familiar face. They were a constant in their lives for the most part, and they can help reorientate people. They can help deliver care, and also, you can have discussion with family, get an idea of the pre-morbid state of the patient, the pre-morbid functioning, and what was important to them, the sort of activities they engage in, and that all can help support the patient both in the ICU, but again, it supports the family with the discharge process. They know what to expect. So during COVID-19, it was really like a big delirium experiment because we went back about 20 years in terms of delirium prevention, in that we had a lot of patients who were very heavily sedated, and they were very heavily sedated for good reasons. And those of you who were here at the time will know that we had a lot of patients who were profoundly hypoxic, a lot of patients being prone. A lot of the time they were being looked after by non-ICU nurses. Occasionally they were being looked after by doctors, which was probably the worst thing of all. Ask Dr. Keeshan about his experience as a nurse. It's highly entertaining. But seriously, we had to sedate people to keep them safe. And when you look at the incidence of delirium and COVID patients around the world, it was much, much higher. So we went back up towards the 80% rate. And some of that might have been, again, related to hypoxia and probably a neuroinflammatory process. We know that COVID was a largely vascular process. There was a lot of vascular inflammation. We saw a lot of patients with strokes with COVID. So that probably had an impact on damaging nerve cells. So we couldn't actually do everything we normally did. Okay, so really to sum up, delirium is bad for patients. It's bad for families. It's bad for the economy. it's bad for us when we're trying to manage them. Yeah, we don't like it. Yeah. We don't really understand it very well. It appears to be multifactorial. It certainly causes physical changes within the brain. And there isn't a magic treatment for it. So in that respect, it's a bit like sepsis. It's multifactorial, and we don't have anything to treat it. We have some strategies where we can aim to prevent it. We won't prevent it entirely, but that will mitigate the consequences. As I say, prevention is better than treating it, because we can treat it. And really, it is a big opportunity for a multidisciplinary approach, working particularly with our nursing staff and therapists and families to try and minimize it. Probably the best resource on the web, so we've got our own PAB guidelines, but actually, if you want to follow up, look at delirium in more detail, I'd recommend that website, ICUdelirium.org. It's run by Vanderbilt University in the States, a guy called Wes Ely, who is an intensivist and geriatrician who has done a lot of work on delirium. There's a huge amount of resource there, both for families but also for doctors. A very good summary of current evidence and things. I'd recommend a look at that. Okay, that's it.